You sometimes think of certain diseases as being sort of distant issues, right? But hepatitis A, well, it's still a big deal globally. We're talking maybe 1.4 million cases a year estimated, and probably more aren't even reported.
Exactly. It's easy to lose sight of it, especially in places with good sanitation.
So that's what we're diving into today, hepatitis A. We've got some really thorough notes here, and the plan is to basically give you the high-yield info, the stuff you really need.
Yeah, think of it as a focused revision session or just a way to get quickly up to speed. We want to pull out those key facts and make them stick.
We'll cover everything, right? From the definition, what causes it, who's at risk,
The pathophysiology, what else it could be, the epidemiology.
how it looks clinically, investigations, management, prognosis, and the complications too.
The whole picture.
Okay, let's jump in. First off, the basics.
Oh.
What exactly is hepatitis A?
Okay, so hepatitis A is essentially a liver infection. It's caused by a specific virus, the hepatitis A virus, or HAV.
And the key way it spreads?
It's the fecal-oral route. That means, contaminated food, water, or even close personal contact. It's not something you catch just by being in the same room, generally.
Right, and how quickly does it show up after someone's exposed?
The incubation period is usually around 2 to 4 weeks. Pretty short, relatively speaking.
And the virus itself? What type is it?
It's an RNA virus, specifically a picornavirus.
Now, a really important point you mentioned earlier, it doesn't usually hang around long term.
That's crucial, yeah. Unlike Hep B or C, hepatitis A typically does not become chronic. People generally recover fully. Symptoms can vary a lot, though, from very mild to quite severe, but actual liver failure is pretty rare.
But you said it can be worse in some groups.
Yes, generally it tends to be more severe in older adults if they get infected. But the flip side is prevention, good hand washing is key, and there's an effective vaccine for people at higher risk.
Okay, so who falls into those higher risk categories?
Well, travelers, definitely. People going to areas where Hep A is more common. Also, individuals who use intravenous drugs, and anyone who is a close contact of someone with an active infection.
And that point about age. Over 50s.
Yeah, even though infection might be less common in that age group in, say, the UK, if they do get it, the mortality risk is unfortunately higher. Really underscores the importance of prevention, like hand washing and vaccination for those eligible.
Right, okay. Definition covered. Let's move on to etiology, the why. What's actually causing this?
Simple answer, the hepatitis A virus, HAV, that's the culprit.
And transmission, we touched on it, but just to be clear.
Primarily ingestion, swallowing the virus, basically. Tiny amounts of fecal matter from an infected person contaminating food or water. Sometimes contaminated objects, fomites, can play a role too, though less common than food and water.
Makes sense. So if that's how it spreads, who is most likely to encounter it? Let's detail those risk factors.
Okay, risk factors. Big one is poor sanitation, so living in or traveling to places without good sanitation infrastructure.
Directly linked to the transmission route.
Exactly. Then there's personal hygiene, not washing hands properly, especially after the toilet or before handling food.
Seems so basic, but clearly vital. What else?
Close contact with an infected person, obviously. Certain sexual practices, particularly those involving oral anal contact, increase risk.
And occupations.
Yeah, certain jobs carry higher risk. Staff in large residential institutions, for example, or sewage workers. Basically anywhere there's potential exposure to fecal matter.
Travel is a big one we keep mentioning.
Absolutely. High-risk areas specifically called out are the Indian subcontinent, Africa, the Far East, South and Central America, and the Middle East. If you're traveling there, vaccination is usually recommended.
Any other groups?
Intravenous drug use is a significant risk factor. And interestingly, people with clotting factor disorders who receive certain blood product concentrates, like factor VIII or IX, are also considered higher risk historically, though screening has improved things massively.
Okay, so the virus gets in. What happens next inside the body? Let's talk pathophysiology.
Right. So HAV enters through the digestive tract, usually, its main target, the liver. Specifically, the liver cells the hepatocytes.
And it just infects them.
It infects them, and that triggers an immune response. Your body sends immune cells to fight the virus, and it's this inflammation in the liver that actually causes the damage and the symptoms of hepatitis.
So it's partly our own immune system causing the illness symptoms.
In large part, yes. The virus then replicates inside those liver cells. This process eventually kills the infected cells, and new virus particles are released, spreading the infection within the liver and getting into the bloodstream.
Where does it go from there to infect others?
Well, humans are the main reservoir. The virus gets released from the liver into the bile, travels through the biliary tree, and ends up in the feces. That's how it gets shed from the body.
And the incubation period, you said 2 to 4 weeks, but sometimes longer.
Yeah, typically 2 to 6 weeks is the range, and there's some thought that the dose, the amount of virus you ingest, might affect how quickly symptoms appear.
When is someone most infectious?
This is key. The highest risk of transmission is actually before jaundice appears. During that prodromal phase, maybe 14 to 21 days after infection, when someone might just feel a bit unwell, like they have the flu, they can be shedding a lot of virus then without realizing they have hepatitis specifically.
Wow, okay. That really drives home the hygiene message. Now, if someone presents with these kinds of symptoms, what else might be on the doctor's mind? What are the main differential diagnoses?
Good question. You need to rule out other causes of liver inflammation. Top of the list are other viral hepatitis types, so Hep B, C, D, and E.
Makes sense. What else?
Alcoholic hepatitis, definitely if there's a history of significant alcohol use. Drug-induced hepatitis is another big one, either a hypersensitivity reaction or direct toxicity from a medication or substance.
Any non-infectious, non-substance related causes?
Yes, autoimmune hepatitis, where the body's immune system mistakenly attacks the liver. Also, sometimes acute HIV infection can present with hepatitis-like symptoms. And other viruses like cytomegalovirus, CMV, or Epstein-Barr virus, EBV, can occasionally cause hepatitis too.
So, quite a few possibilities to consider. Needs careful investigation.
Absolutely, you need the right tests to narrow it down.
Let's zoom out then. Epidemiology. Where does Hep A fit in the global picture? And what about here in the UK?
Globally, it's very common, especially in less developed parts of the world. It's actually the most common cause of acute viral hepatitis worldwide. Those high-risk regions we mentioned, Indian subcontinent, Africa, Far East, South Central America, Middle East, that's where the burden really lies. That 1.4 million estimated annual cases reflects this, and it's strongly tied to socioeconomic factors, sanitation, access to clean water.
And the UK picture.
Much rarer here, thankfully, mostly due to good sanitation and vaccination for travelers and at-risk groups. Cases we do see are often linked to travel, but outbreaks can still happen, especially in those risk groups we identified. The notes mentioned 503 cases in England and Wales in 2019, likely an underestimate.
And why is it rare? Just sanitation or?
Primarily sanitation and vaccination, but also because fewer people are exposed as children in developed countries, there's less natural immunity in the population, meaning herd immunity might be lower if an outbreak starts.
Interesting. Okay, so if someone does get it, what does it actually look like? The clinical features?
It can really vary. Some people, especially young kids, might have no symptoms at all, or just very mild ones. It's called subclinical infection.
But for those who do get symptoms?
Often starts with quite nonspecific stuff. Feeling really tired, losing your appetite, feeling sick, maybe some discomfort in the abdomen, and a fever. It can mimic the flu initially.
And then the classic sign.
Jaundice, yeah. The yellowing of the skin and the whites of the eyes, that's a big clue pointing towards the liver. Along with that, people might notice their urine gets quite dark, like tea-colored, and their stools become pale, sort of clay-colored.
Any other common symptoms?
Muscle aches, joint pain can happen. Sometimes the liver and spleen might be enlarged and tender to touch. That's hepatosplenomegaly.
You mentioned a prodrome.
Yes, often there's this phase before the jaundice hits, maybe lasting a few days to a week or so, where the main things are that loss of appetite, just feeling generally unwell, malaise, maybe some joint pain. Abdominal pain is common too, usually in the right upper quadrant over the liver.
And that tenderness.
Tender hepatomegaly, yeah. The liver feels sore when pressed. Remember, the incubation is usually 2 to 6 weeks. When the jaundice phase, the icteric phase, starts, some people also get quite itchy skin, which we call pruritus.
How long does it all last?
Recovery can take time. While the acute illness might resolve in a few weeks, getting back to full energy can sometimes take up to 6 months for some people.
Okay, so quite a range of presentations. How do we confirm it's definitely Hep A? What investigations are key?
The definitive diagnosis comes from blood tests looking for specific antibodies against the virus. The crucial one for diagnosing a current infection is the IgM antibody to HAV.
IgM for minute or moment, meaning recent.
Exactly. Think M for me now, or mainly recent. It pops up right around when symptoms start, usually 3 to 4 weeks after exposure, and hangs around for about 3 to 6 months. If that's positive, it means acute hepatitis A.
And what about past infection or vaccination?
That's where the IgG antibody comes in. Think G for gone or got immunity. IgG appears soon after IgM, but it persists for years, often in lifelong. A positive IgG with a negative IgM usually means you've either had Hep A in the past and recovered, or you've been successfully vaccinated.
What about the standard liver function tests, the LFTs?
They're very useful too. You'll see a big spike in the liver enzymes, ALT and AST. Usually happens around the time symptoms start, maybe 4 weeks post-exposure. Typically, ALT goes higher than AST in hepatitis A, which can be a helpful clue.
And other LFTs?
Alkaline phosphatase, ALP, often rises along with ALT and AST. Bilirubin levels increase too, usually a bit after the enzymes peak, and that's what causes the jaundice. Bilirubin can stay high for quite a while, even months.
Anything else in the blood?
You might see a slight drop in serum albumin, which is a protein made by the liver. Prothrombin time, which measures clotting, is usually normal. But we might check it if the case seems unusually severe or we're worried about complications like liver failure. Sometimes mild signs of red blood cell breakdown or a slight increase in lymphocytes. Very rarely, more serious blood count issues can occur.
Is imaging useful, like an ultrasound?
Not usually needed just to diagnose Hep A itself. The blood tests are pretty specific. But an ultrasound might be done sometimes if the picture is unclear, perhaps to rule out other things like gallstones or other structural liver problems.
And just to circle back on vaccination, that creates the IgG response, right?
Precisely.
Yeah.
The vaccine prompts your body to make those protective IgG antibodies without you actually having to go through the illness. It's highly effective and recommended for travelers, people with chronic liver conditions, certain occupations like lab or sewage workers.
Okay, diagnosis sorted. What about managing it? If someone has Hep A in the UK, what's the approach?
Management is mainly supportive care. There's no specific antiviral drug to cure hepatitis A, so it's about helping the body heal itself.
What does supportive care involve?
Rest is important. Good nutrition, stay hydrated, monitoring liver function with blood tests to see how things are progressing. And, crucially, avoiding alcohol completely until the liver enzymes are back to normal, because alcohol puts extra strain on the liver.
Do people often need hospital admission?
Not usually.
Fair
Most
enough.
people can manage at home, but if someone gets severely ill or maybe they can't stop vomiting and get dehydrated, then hospital admission might be necessary for IV fluids and closer monitoring.
Any special considerations?
Pregnant women might need closer watching as they can sometimes have a more severe course, and preventing spread is vital. So advising the infected person on hygiene, like not preparing food for others, and avoiding unprotected sex during the infectious period. Public health teams often get involved too, especially if there's an outbreak, to help with contact tracing and control measures.
So really, it's about rest, fluids, avoiding toxins like alcohol, and preventing spread while the body does the work.
That's the essence of it, yes. And remembering that prevention through vaccination is the best strategy overall for those at risk.
What's the outlook then? For someone who gets Hep A, what's the typical prognosis?
Generally, it's excellent, really good. Most people recover completely, usually within a few weeks to a couple of months, maybe longer, to feel fully back to normal.
And importantly, no long-term liver damage usually.
Correct. Hepatitis A does not cause chronic hepatitis or chronic liver disease. Once you've cleared the virus, that's usually it. Severe illness and complications are quite rare, particularly in younger, healthy people without underlying liver problems.
That's definitely reassuring. But we should cover the what-ifs. What are the potential, albeit rare, complications?
Right. While uncommon, they can happen. One is cholestatic hepatitis, where bile flow from the liver is blocked up, causing more prolonged jaundice and itching. That occurs in maybe around 8% of cases.
And the really serious one.
Fulminant liver failure. This is acute liver failure, very severe, life-threatening. Thankfully, it's very rare, less than 0.4%, so less than 1 in 250 cases.
Any others?
Some people, maybe up to 15%, can experience a relapse. They seem to get better. Then symptoms come back for a bit before finally resolving. And there are other extremely rare complications described.
And severity relates to age again.
Yes, severity and the risk of death are higher in older adults. If acute liver failure does occur, the mortality rate is significant, around 40%. So, while generally mild, it can be serious for some.
All the more reason to focus on prevention. Let's just quickly recap those key prevention strategies one last time.
Absolutely. Number 1, vaccination. Crucial for travelers to endemic areas and for those specific high-risk groups. Number 2, hygiene. Meticulous hand washing, especially after using the toilet and before handling food. Being careful with food and water in high-risk areas, avoiding tap water, uncooked shellfish, things like that.
And public health measures.
Yeah, public education about how it spreads and how to prevent it. Plus, good infection control practices like notifying public health authorities about cases, contact tracing to offer post-exposure prophylaxis vaccine or immunoglobulin. Where appropriate, these are vital to stop outbreaks.
Okay, great. So wrapping up the key points for everyone listening. Hep A is spread fecal orally. Think contaminated food water, doesn't usually become chronic. Management is supportive rest, nutrition, avoid alcohol, and prevention is key. Vaccination and good hygiene are your best tools.
Exactly. And maybe a final thought to leave people with, given how effective the vaccine is and how we understand transmission, what do you think are the biggest remaining challenges to actually controlling or even eliminating hepatitis A on a global scale, especially in those high prevalence areas? Something to ponder.
That's a really important question. Now, for anyone wanting to solidify this knowledge or revise other topics, do check out past.msra.com. They've got lots of great resources.
And for additional free materials, you can also look at freemsra.com.
Brilliant. Thanks so much for joining us for this deep dive into hepatitis A.